Good afternoon. I'm Tom Berney. I'm a retired developmental psychiatrist who's chair of the SIG in neurodevelopmental disorders. Last month, we published the latest revision of the college's guidelines on the psychiatric management of autism in adults, CR228. And this document is not about autism as such. It's written for psychiatrists who, in the course of their work in adult mental health, are going to see people whose psychiatric problems are complicated by their autism. Although the prevalence of autism is roughly 1%, our guess is that this will apply to about 4% of the people that these psychiatrists see. And our aim is to write guidance that is brief and readable and has been written in consultation with a large number of people, including autistic adults. I'll hand you over this afternoon with picked three topics out of this, and I'll hand you over to Ian Davidson, who's going to talk about autism and mental health. Ian is a consultant general psychiatrist who's employed by the Cheshire and World Partnership. And he, besides being the lead psychiatrist in their adult autism team, he's the autism champion of the Royal College of Psychiatrists and has a variety of other posts as well, which has given him a broad insight. Ian?
Right, thank you, Tom. So, hello everyone. I'm just going to switch my timer on so I don't overrun. The presentation I'm about to do, as I say, I'm giving credit to Rachel Moody and Claire Hayden, because normally we do this presentation over a half day or a day. So this is very much edited highlights. But the slides are going to be available for everyone. So although I'll skip through some slides, they will be available to you all to look at afterwards. There is further reading at the end, and my contact details are available as well if anyone wants to follow up. And this national picture, the 32 billion a year, what we say about that is that's the cost of getting it wrong. That's not the cost of autism, that's the cost of not delivering services for autistic people in the correct way. Why is it unnecessary? There's a high rate of premature mortality and a high rate of suicide. I know that Conor is going to be covering this in more detail, so I will go on from there. I know that the college covers multiple jurisdictions, and so there are different laws, different policies, different approaches in the 4 UK different countries, and then further afield beyond that in the international divisions, etc. So please, when you're making use of this, think about your local rules. I am talking here very generically to avoid coming into too much conflict with any local rules. This says what is being autistic like. I'm not going to cover this in any detail because you're going to get a lot more about this from Mary. The reason why I put this slide up is that we deliberately in this slide, we take the criteria which are in ICD-10 and they're reduced slightly in DSM-5, but they're the same. And what we say is it's not just the negative, because coding tends to be about disorder, therefore tends to be very much negative and impairment based. What we're saying is all of these traits have got negative and positive impacts for that person. And what does not tend to feature very much in the criteria for diagnosis, sensory hypersensitivity and hyposensitivity often have a big impact on the person. They have got both positive and negative impacts again, but they particularly in relation to mental health and accessing health services, they can be the most important factors. So it's positive and negative, and we keep stressing that it's about strengths, needs and aspirations. It's not about a whole list of impairments. Put in here some strengths, because often, as I say, there's too much focus on impairments and not enough focus on strengths. Every single human being is better at some things and worse at other things. The skill of being a successful human being is playing to your strengths and learning to minimize those weaknesses which get in your way. It's the same for autistic people. What we want is autistic people to be successful as being themselves, not to try and be something else. Barriers for autistic people accessing healthcare. Now, these are large. They contribute enormously to the premature mortality and premature morbidity, because virtually all of that is due to preventable and treatable conditions. One of these applies to autistic people themselves, which is the first one, which is that autistic people can find it difficult to put into conventional language how they're feeling, particularly around their own emotions and feelings. And communication difficulties can occur when autistic people are very stressed or overloaded. They can find it more difficult to explain themselves. And so those things do happen, but the other three then are about the response by health services to them, which make that worse. So one common experience is autistic people not being listened to or taken seriously when they're trying to communicate their distress. This is because they are seen as camouflaging. Camouflaging is what you do when you're trying to hide things. All human beings camouflage and mask to some extent. Autistic people are often said to be camouflaging and masking when they're actually trying to simply get by and try and avoid negative responses to themselves. But often what's called camouflaging isn't camouflaging. It's simply that they do not use conventional non-verbal communication. So, for example, if someone's smiling, it does not mean they don't have a burst appendix, and they just may not be showing the conventional non-verbal communication to show they're in pain. Accessibility of GP surgeries and mental health services. When we went to having largely telephone-based access, this actually became an additional barrier to many autistic people. It is not just a barrier to autistic people in my getting it right first time role for crisis acute mental health. I'll be stressing it's a barrier to many people, but telephone access is very difficult because you have to think quickly on the spot. You get very little feedback from the other person, and there's often issues with the range of communication that can be done. And so what we are saying is one way around that is simply to have things like text and email as an alternative. And there are lots of other alternatives, but those are two common ones. And then a lack of understanding of autism amongst mental health professionals with limited training, misconception, differential diagnosis. When we did a survey on this, which was published a year ago, what was clear was a lot of psychiatrists had very little training in autism or mental health aspects and presentations of autistic people. And so we through the Health Education England and with cooperation with the Royal College of Psychiatrists, we put on a range of training days called Autism Essential for Psychiatrists, which were heavily overbooked. And this is a quick summary of what we cover. What's really, really important is avoid making assumptions based on body language. It's well known that we all tend to make judgments very quickly. That's human nature, and we tend to base it on what we see. Observation is the least objective way of assessing a situation, and we do it, but we basically do it based upon our internal thinking and what we're trying to look at. So we miss lots of things we're not trying to look at. So do not judge an autistic person's presentation on body language. This is particularly important in mental health services, where increasingly people are talking about positive behavioural support, which is very much based upon interpreting body language. It is unhelpful for autistic people to do that. You're much better saying to the autistic person, what's troubling you, what's distressing you, and what can we do to help? Check you've interpreted the autistic person correctly. Nearly everyone that we see in adult diagnostic service has got low self-esteem because they've spent their lives being told, you're the odd one out, you don't understand, you make mistakes. What we do right at the beginning of our assessment is say, we're human beings, we make mistakes, we misunderstand people, so we're going to feed back to you what we think we've heard from you, but please correct us if we're wrong. And that's a very simple thing to do, which completely then puts them much more confident to actually say, no, I think you got that wrong. Understand that they may not use conventional ways of expressing emotions and may not use conventional ways of asking for help. And again, if it's someone showing behaviour that looks like they're agitated or whatever, then it's probably because they're either very excited or very distressed, so ask them. There are certain things that can be used. For example, if people have got difficulty being verbal when they're stressed, they can do things like use wristbands of different colours to say whether or not they wish to be spoken to at the moment. They can write notes. For non-verbal autistic people, there are a range of ways of doing that. Like I say, for many autistic people, texting, emailing, even if they're in the same room can be very beneficial. So why does it matter? As Tom said, we now think it's at least 1.1% of the population are autistic, and some studies suggest higher than that. Most autistic people alive today weren't diagnosed at school, so a lot of them have been in services for years, but were not necessarily identified and were not necessarily getting reasonable adjustments made. It does not disappear in adult life, it continues through adult life. And just some information there. I'll come back to learning disabilities later. But most autistic people of all ages will be accessing mainstream services for physical and mental health care needs. So it is general old age, forensic, psychotherapy, rehab, psychiatrists, of all those various different types are the ones who are most likely to be working with autistic people, not CAMS and LD services. Because of all of that, little's known about the natural course of life for autistic people and what promotes success. But as it's increasingly now becoming evident that if people know they're autistic, understand their own milieu of traits and sensitivities, understand what works for them, and are then able to build on those strengths, this reduces things in terms of negative experiences, and also helps other people to work with them because they know what is useful. That's why we encourage autistic people contacting services to use things like hospital passports, because most professionals are stressed and under pressure and rushing. And if you're bombarding someone with questions, they tend to freeze up, you tend to get stressed. So it's much easier if it's written down. It gives the autistic person a chance to write it down when they're thinking clearly, and it gives the mental health professional a chance to read it, which is quicker than actually listening to someone. Won't cover this because I know Conor's covering it. But again, what we're saying here is this is nearly all avoidable, and it's really important to avoid it. Social exclusion includes things like bullying, and so most of the mental health problems that autistic people develop in adult life are driven by social factors. There will be some contribution from genetics, there will be some contribution from adverse childhood events, but like most adult people, what tends to precipitate relapses and onset of presentation are things happening in the person's current life, which will then be coloured by things that happened to them in their earlier life. Is it a disorder or not? The secondary and social interaction communications are extremely common in many mental disorders, which we'll come back to later. But if someone suddenly starts to develop significant secondary social communication, social interaction difficulty after not having had them through their childhood and teens, it's highly unlikely to be autism. Equally, an autistic person has been autistic all their life. If they suddenly start developing all sorts of other things which you would typically attribute to mental disorder, then it probably is due to mental disorder. Differential diagnoses, there's a lot on this. I'm not going to try and cover it all, but it's really important to think about it. CR228 has more information on it. I've got information in the next few slides, but please, please, please feel free to contact me if you want more information. And what's critical here is that autistic people typically have smaller social networks than non-autistic people, and so they've got less access to informal support and advice, and particularly if a key person in their life is not available, this can make it harder to get access to help and harder to get support when you need it. EUPD, one of the problems with EUPD is we label things as personality disorder when they're not actually about people's personality, which you can't change. They're about how people have developed and used coping strategies frequently in response to trauma, which you can change. But by and large, EUPD presents with significant difficulties in social communication and social interaction. It gets labelled all sorts of horrible things, but actually these are people trying to communicate their level of distress, and they get told they're attention seeking and all the rest of it. They're not. If you see that someone's attention seeking, what you're actually saying is they've got really poor social communication, social interaction skills, because it's so obvious they're seeking attention. If you're skilled at it, it's not obvious. Con men aren't obvious when they're seeking attention. So really important here that it is difficult sometimes because a lot of autistic people have had trauma, but actually taking a proper history and looking at when the trauma was and when the trait started usually helps to split the two. Having said that, autistic people are exposed to lots of trauma, and unfortunately many of them have suffered abuse in childhood, so they can also develop the maladaptive coping strategies which form EUPD. Those are treatable. Autistic traits are being part of who you are. They are not only not treatable, but they're who you are. It's like back in the old days when people tried to make left-handed people right-handed, it just simply caused them problems in mental health problems. Trying to make an autistic person into a non-autistic person simply causes mental health and other problems, so don't do it. Whether it's autism or psychosis, psychosis is not a euphemism for schizophrenia. This is a major issue in mental health. And people say someone's not psychotic because they haven't got schizophrenia. If you have got psychotic symptoms and signs, you have got a psychosis. It may be a transient psychosis, it may be driven by multiple other conditions, but you need to understand what the cause is, otherwise it will be recurrent. Psychotic symptoms may occur in autistic people for a wide variety of reasons. It's important to treat them when they occur. They are not part of the autism, but it's also important to understand whether or not they are likely to be long-term or whether or not they are brief, and you then need to look at prevention of further episodes. Be careful how your symptoms are elicited. Autistic people tend to be very frank and quite literal in their interpretation. So if you say to them, do you hear voices? They will of course say yes, unless they really are deaf. They may have an increased acuity of auditory experiences, so they may say yes to the hear of voices that they don't hear, but that's just normal. OCD, really important that you don't call things OCD when they're not, but equally if they have got distressing compulsive behaviours, that is not autism, that's OCD and needs treating. Catatonia is not a diagnosis, it's a state. Again, very common hyperarousal. Suicide, you're getting covered. More stuff here. Orphied is becoming more well known. It's been around for many years. It's treatable, but it's different type of treatment to anorexia nervosa, bulimia nervosa. PDA is not a diagnosis, it's a trait pattern which can occur in autistic people. The vast majority of autistic people don't have learning disability, so they shouldn't be going to learning disability services, they should be coming to your services. Diagnostic overshadowing, as we've said, please don't say it's autism. If it's new, it is almost certainly not autism, it's new. Reasonable adjustments are very easy to do. We can give you a whole talk on that. We can give you loads of examples of what sort of reasonable adjustments you can put in place in adult and older services. They are not about producing perfect environments. No inpatient environment is perfect for everyone. Here is a checklist which will be available on the slides that we created for our crisis team, so that when people present in distress, they've got a quick reminder of the right things to do. Get their self-esteem and confidence up, and most people are then much better at seeking help and getting reasonable adjustments. So the best thing you can do is support someone to recognise their own strengths and work to achieve their own aspirations. Thank you very much. Further reading there. Back to Tom.
Thanks, Ian. As Ian says, you can go back to CR228, that can be downloaded from the college site to get that in much of that in more detail. Mary Doherty is a consultant anaesthetist in Ireland who's been involved in autism research and is looking at the moment for the barriers to healthcare for autistic adults and the experience of autistic adults and getting healthcare. She is autistic. She is the founder of the peer support and advocacy group, Autistic Doctors International. I think this is an important area, and I'd pass you across to Mary now to talk about autistic doctors.
Thanks, Tom, for the introduction. I'm delighted to have been part of the working group on CR228 and to talk to you all today about my work with Autistic Doctors International. I'll start with my main message, and it's this: we exist and you might be one of us. Some of you will already know or suspect that you're autistic, and for others that light bulb moment may happen as I speak. Know that you're not alone. There are loads of us in all branches of medicine, and we're a friendly and supportive group, and finally finding our true peers has been incredibly positive. I'll tell you at the end how to join us. Some of you may know me from Twitter, where I tweet as the Autistic Doctor, but for those who don't, I'm an Irish consultant anaesthetist, and 7 years ago, after I'd given up work to care for my child, I was also diagnosed with autism. I'll be honest, I was terrified for my career at the time. Can you be autistic and work as a doctor? I had no idea. Now I know, yes, of course you can. So I work in a small general and orthopaedic hospital in Ireland, similar to a district general hospital in the UK. And here's my other job. I'm also a qualified ski instructor, And this is me teaching in Andorra recently. And I usually spend my winter weekends teaching on the dry slope at the Ski Club of Ireland. This is my munchkin. He's 12 now, but his diagnosis at 6 was late, given his presentation. I had dismissed concerns because, well, I'd been just the same as a kid. Lots in my family were. The diagnosis finally explained a lifetime of personal and professional difficulties, and I wonder, how on earth did I get to be a consultant anaesthetist in my mid-40s before anyone noticed? Including, it must be said, several psychiatrists who I'd seen over the years. But there was little known about autism back then, particularly for women. And the quote is the start of a blog post I did recently for the Royal College of Physicians as part of their This Doctor Can campaign, which celebrates diversity and inclusion and equality in medicine. Oh, but I felt so alone back then, confused, craving a connection. I searched, but I just struggled to find even other autistic parents, never mind other autistic doctors. And despite being involved in the general autistic community, I knew I needed to find those who would really understand. So I set up Autistic Doctors International in April last year. And now we have over 150 medical doctors from all across the globe, all delighted to connect with each other in a very active Facebook group with a linked group for medical students. And as well as peer support, we're becoming active in training, advocacy, and research. I first spoke about this at the European Association for Physician Health conference last year with my friend and colleague, Dr. Shirley Moore, where my main message was something I realized on my return from my career break. Medicine selects for Aspie traits. Lots of us actually meet the criteria for diagnosis. All is good until demands exceed capacity to cope, and then the wheels fall off. Autism should be specifically considered when doctors present in difficulty. That tweet's a bit old. I don't use ASD anymore. I prefer condition to disorder, and mostly I just use autism. Science and academia also select for autism, yet due to the current stigma around the condition, most of us remain in hiding. I hope we can help change that culture so it's possible to come out as an autistic scientist, doctor, academic, and have our contributions valued without fear of negative career impacts. We know little of the prevalence of autism amongst doctors. In a Knowledge of Autism survey by Unigwe et al., 1% of GP respondents disclosed that they were autistic themselves. And we know of at least 18 doctors where an autistic spectrum condition was identified in GMC fitness to practice proceedings. There may be many more. You can expect at least 1 to 2%, possibly more. You may have seen this recent publication by Shirley in The Lancet Psychiatry, which refers to the increasing numbers being recognized and reaching out. And despite a wide range of specialties, including a number of psychiatrists, we share common challenges, particularly around anxiety, transitions, communication and sensory issues, and difficulties accessing supports. My career prior to the break was anything but seamless. My undergraduate years and postgraduate training was spent just lurching from one crisis to another, and in hindsight, all were due to unrecognized autism. Throughout my clinical years, I excelled with patients but struggled with peers. I can confidently state that without the diagnosis and the awareness that it brought, I wouldn't have even attempted to return to practice. And now I'm not for a moment denying the heterogeneity of presentation or the serious disability associated with autism. But when talking about a group of autistic doctors, we're looking at highly intelligent, high-achieving individuals who nonetheless experience significant discrimination and stigma. The main issues for me on a daily basis are social and sensory. I now have excellent interpersonal skills, but it's cognitive, it's not intuitive, and it can be exhausting. And some of the issues we face are qualitatively similar to those, qualitatively similar to those who might be more visibly autistic, particularly around sensory challenges. I can be very noise sensitive and light sensitive. This picture is how an office might usually look. And that's how it can look on a high stress or a bad lights day. And while lots of autistic doctors are managing well, particularly those of us who have found a nice square hole to fit ourselves into, the recurrent narrative amongst autistic doctors known to me is one of personal distress, professional difficulties, and often a truncated career. Early retirement is common, and indeed after such a long break, that was expected of me too, amongst some of my clinical colleagues. We know the mental health statistics, and we know the common presenting issues. Particularly note borderline personality disorder, or EUPD, as Ian referred to. And also note that neurodevelopmental conditions often don't come alone. So remember ADHD, dyslexia, dyspraxia. Most of our group feel their mental health has improved since joining us. We've developed deep friendships, helped struggling doctors manage challenges at work, and supported others through career changes. We've advocated for members suffering discrimination and misunderstanding, and we've been there for those going through acute crises. After speaking to the NHS Practitioner Health Service last year, several autistic doctors presenting to their service have been identified, referred on for diagnostic assessment, and then to us for peer support. Let's consider for a moment the positive traits associated with autism: attention to detail, deep focus, novel approaches and creativity, pattern recognition, resilience and tenacity. Aren't these exactly the qualities we would want in a doctor? Lots of you will recognize Dr. Temple Grandin, at one point the most famous autistic advocate worldwide, who says, "The world needs all kinds of minds." Where were we? Let's go back to this one. Okay. The concept of a condition, once considered pathological before being recognized as a form of diversity, has echoes in the gay rights movement. And sometimes when I talk about being an autistic doctor, I think of Dr. H. Anonymous, later identified as John E. Fryer, addressing the 1972 American Psychiatric Association Convention, who stood up on behalf of what they termed the gay PA, wearing a mask and using a voice distorting microphone, and said, "I'm a homosexual, I'm a psychiatrist." This is when homosexuality was not only considered a disorder, it was criminal. And look at the difference in societal attitudes over a generation or two. Even more interesting is Dr. Robert Spitzer, who died in 2015 and who has become my newest hero. I first heard of him when I read Neurotribes by Steve Silberman. Alan Francis, chair of the DSM-4 task force, tells us he was responsible for the removal of homosexuality from DSM-2 in 1973, which was the result of his single-minded and almost single-handed crusade to eliminate the psychiatric stigmatization of difference. His other major accomplishment was to save psychiatry from a crisis of credibility with the development of the DSM-3 and its subsequent revision. He had a particular sort of mind, one I recognize. He was known to be obsessed with diagnostic reliability. He developed software for computer-assisted diagnosis back in 1965, when few psychiatrists had even seen a computer. Let's look at what his colleagues said about him, and look particularly at the underlined one, treating everyone equally without respect to rank or previous accomplishment. That's certainly something that those of us in the autistic doctors regularly get into trouble with. He said of himself that he had difficulty giving gifts, for example, because he had no idea what others would like. This is the man who's been credited with saving psychiatry itself from extinction. To quote Steve Silberman, "While Spitzer's eccentricities may have fallen short of meeting the criteria for Asperger's, the DSM-3 was the product of a mind that exhibited many classic qualities of autistic intelligence. Wouldn't it be the most supreme irony if the man who created the Bible on which modern psychiatry is based was one who thought like us? What more evidence could we need that diversity of thought within medicine is vital and that we need to recognize and celebrate neurodiversity? But we need to challenge the stigma and unconscious bias around autism that is so pervasive in society, but particularly in medicine and academia. I personally know 2 other consultant psychiatrists who know that they're autistic, but who don't feel able to disclose or won't even join the private group because of fear of the impact if it was known. What would you feel at my suggestion that you might be autistic? Indignation, fear, shame, hope? This matters because we know the cost of masking, the impact of lost careers, lost well-being, lost lives. I believe much of the poor mental health outcomes for autistic people, including our 9-fold suicide rate, is down to the pathology paradigm, which considers autism as something bad, something broken. Can you imagine getting the message since your earliest days that you are at your core somehow wrong, that you need to be fixed? Again, I'm not for a moment denying the serious disability associated with autism or the heterogeneity in presentation, but the way in which autism is framed has a profound effect on outcome. The autistic kids and adults I know who are doing well, who are content and confident, are those who are either accepted and supported through childhood or who have put enormous work into trying to overcome the harmful effects of ableism and stigma. I'd recommend the work of Dr. Damien Milton on what he terms the double empathy problem as a good starting point here. High-achieving autistic doctors commonly mask difficulties up to a point of catastrophic decompensation, which can come seemingly out of the blue. However, with awareness of the specific challenges arising from autism, in my view, many of us can be supported and retained or returned to practice. The benefit of diagnosis is enormous. We realize that we are not broken versions of normal, that we are, to quote Temple Grandin, different, not less. Self-awareness is key. Knowing that my challenges were due to autism meant that I could learn to manage them effectively. To learn more, the first recommendation in CR228 is a good place to start. Become familiar with the challenge, with the autistic world. It does seem like a parallel universe at times, and for most of us, feeling so different, even as children, to the point of wondering if we were aliens is a common experience. And that's a key question for anyone thinking this might fit for you. Did you feel different to your peers, even as a child? Don't assume that you understand autism unless you really do. It's easy to recognize once you know it, but medical or even psychiatric training generally doesn't prepare us, and often our concept is based on stereotypes or what limited exposure we have had. But autism is one of the most heterogeneous conditions in terms of presentation, so beware of that knowledge gap. While understanding of autism is increasing, thanks to the work of my colleagues here today, it can still be challenging to find specialist advice in some regions, but it is vital. Remember, I'm autistic and I knew nothing about it until I had to. So in summary, remember to add autism to the differential diagnosis, resist the tragedy narrative, and remember that we can be good doctors. We will continue to raise awareness through various upcoming publications, research and advocacy projects. We'll present a workshop on supporting autistic doctors at the upcoming International Conference on Physician Health to be held in London next April. Watch the BMA website for details on that. And to join the private group, either send a message to the public Facebook page or contact me directly. Thank you for listening. Let me pass you back to Tom.
Thanks, Mary. Questions we'll take at the end after Conor's spoken. Conor will introduce himself, but he's a consultant psychiatrist from Leeds, who's the lead for the autism diagnostic service there, and we'll talk about suicide. Conor, thanks.
Thanks very much, Tom. I'm just going to get my slides up. Okay. Oh, I've gone too far. Let's go back to the start. Okay. I'm just going to, hello everybody, I'm Conor Davidson. I'm just going to indulge myself for a second and talk a little bit more about my professional background before we get into the topic of autism and suicide, because I think it's relevant for you to understand where I'm coming from in this topic. So I'm from Northern Ireland. This is me there on holiday, actually, in a place called Inishkeel, sitting on the rock there last week, no doubt contemplating what I'm going to say in this talk today. But then I moved to York and I trained in psychiatry in York, and then I became a consultant in CMHT in Bootham Park Hospital. And over the years then I developed an interest in autism. But really I'm coming at this topic as a general adult psychiatrist with an interest in autism. So I'm pitching it to, you know, a general psychiatrist, really. You don't have to be a specialist to know about this subject. I can't quite leave it there because this year I moved to a new job in Leeds with the specialist autism team there. And as a Leeds United fan, I do have to show this picture, I'm afraid, which I think speaks for itself. It has been a good year from that point of view. So why should autism be the business of mental health services? Why should you, the psychiatrists in the audience, care about autism? Well, we've heard already that it is a common condition, so it affects about 1 in 100 people in the UK, but amongst psychiatric populations, it's even more common. So up to 1 in 20 psych patients will have autism. So you will come across autistic patients in your daily practice. It's under-recognized, so around half of autistic adults are undiagnosed or misdiagnosed. And it's a complex condition. So both mental health and physical health comorbidity, sometimes multiple morbidity, is the rule rather than the exception in adult autism. And there's high rates of risk in this population as well, not just suicide, which we're going to talk about now, but also other risks like self-harm, bullying, abuse, and exploitation are all higher. I'm going to use a case example now to kind of hang some of the presentation around, just to illustrate what I'm talking about. So you see Lizzie, who's a 25-year-old female in your outpatient clinic, and she's single and lives with her mother. Her presenting complaint is increased anxiety and low mood following a relationship breakup. And Lizzie has a history of adult autism, anxiety, depression, and fibromyalgia. And she also has restricted diet and poor sleep, and few friends or sources of support besides her mother, who herself has been physically poorly recently. So immediately when you're reading this, you should be thinking about what risk factors are present. So Lizzie's female, which you wouldn't normally expect to be a risk factor for suicide, but in fact in autism it is. So that gender difference is reversed in autism. She's got anxiety, low mood, so we know that psychiatric disorder is a risk factor for suicide, and in particular depression. She's had a relationship breakup and her mum's been poorly recently, so these are life events and changes. People with autism are kind of more sensitive to life events. Sometimes changes in life that may seem even relatively trivial to you can be very significant to an autistic person. Like a lot of the patients we see in clinic, Lizzie has comorbidities, so anxiety, depression, fibromyalgia. That's more common in autism, as is chronic fatigue syndrome. She's got a restricted diet, and eating disorders are more common. All kinds of sleep disorders are more common as well. And she's got a sort of limited or reduced social network, again, which we see in a lot of people with autism. So I'll come back to the risk factors in a second, but I'm just going to show you this study now. I don't have loads of research papers in this presentation, but this is one that I think all psychiatrists should at least be aware of. It was a Swedish case register study from a few years ago, published in the British Journal of Psychiatry, and really big numbers here, so over 27,000 people they looked at. And the headline here is that the risk of death by suicide in adult autism was 9 times higher compared to the general population. So it was a really striking finding and caused a big splash in the field of autism at the time. And that finding's been backed up by other research. So Sarah Cassidy is the leading researcher in the UK on this topic, and she's found that 2/3 of autistic adults have contemplated suicide. We know that rates of self-harm are high in autistic populations. As I say, the risk of death by suicide is multiple times higher, and it's not just this study, it's other studies that have found that. And the risk is greater in females with autism, interestingly. So why are people with autism more likely to die by suicide? So I've divided this slide into sort of 2 columns. On the left are some general risks that are kind of applied to the general population but are more common in autism, and on the right are some autism-specific risks. So you can see on the left here, high rates of psychiatric comorbidity, higher rates of self-harm, unemployment, weaker support networks, feeling a burden on others, higher rates of bullying and abuse. All of those things are more common in autism. And on the right-hand side, some more autism-specific risks. So unmet support needs, high rates of camouflaging, which Ian mentioned. So camouflaging is, you particularly see it in high-functioning female autistic people, and it's where they kind of mask their autism features in order to fit in better. And that's independently associated with higher suicide risk. Cognitive rigidity. So this is an interesting one. A lot of people with autism are quite rigid in the way they think. And we do see in our clinics autistic people who come across a kind of what seems to be an insuperable problem in their lives, and a kind of logical train of thought process that leads them to conclude that suicide is a logical solution to the problem. once they're on that train of thought, it's quite difficult to divert them from it. Lack of imagination. So again, this is interesting. Some autistic people struggle to conceptualize the consequences of what will happen, what suicide is. So for example, the impact on their friends and family of them taking their lives, their own life, or indeed the concept of death itself and the finality of death. We know that transition points increase the risk, for example, moving from school to university or changing jobs. And this final one is interesting. It's more based on anecdotal evidence than research evidence, but there's a suggestion that autistic people may use more lethal and more painful methods to attempt suicide. And that could be due to the sensory issues. So people with autism often have a higher pain threshold. I had one patient I saw in clinic who was suicidal. He went into a kind of secluded wood and he attempted to saw off his forearm with a hacksaw. And I said, how long were you doing that for? And he said, 15 minutes. I said, wasn't it just so painful? And he kind of just shrugged. So his pain threshold was so high, he could literally saw at his arm for 15 minutes. On that slightly grim note, I'm going to go back to the case example. So back to Lizzie. So looking at her history, she's got a history of depression and social anxiety. SSRI antidepressants have made her hyperactive, so she's on no medication. And we often see that in autism, that people with autism have these idiosyncratic reactions to psychiatric medication. Lizzie says she often has thoughts of wanting to not be in the world. She used to self-harm, but not in recent times. And on mental state examination, she appears flat in affect with reduced rate and volume of speech, and describes the relationship breakup and having nothing to live for anymore in a kind of matter-of-fact way. But then when you ask her how her mood is, she says, oh, I feel the same as usual. So this illustrates some of the issues we see in risk assessment in autism. Bear in mind the psychiatric appointment itself may be very stressful for the patients. So they may be seeing a new person in a new environment and feel overstimulated. So you have to take that into account. Also, autism itself can affect the mental state examination. So Lizzie appeared to be flat in affect and reduced in her rate, rhythm, and volume of speech. But some autistic people, that is, you know, how they are at a baseline, you do sometimes get reduced facial expression, reduced tone of voice. So it's really important that you know what your patient is like normally and has there been any change. Communication, so people with autism sometimes have a more literal way of describing things and explaining things, which can make it more difficult for them to explain kind of the suicide risk or how they're doing. And likewise, the kind of other way, the receptive communication, it can be difficult sometimes for autistic patients, even people with very high IQ, to take in what you're saying if they're feeling overloaded or overwhelmed. So it is worthwhile considering backing up what you're saying with written material or even picture material. Difficulty describing internal states. So we do see this a lot in clinic. People with autism, again, I don't want to overgeneralize because all autistic people are different, but quite often people will have problems describing how they feel. And that can include describing kind of mood states. So in Lizzie's case, we asked her, how do you feel? She just said, oh, the same as normal. And people can sometimes describe quite extreme risks and extreme suicide plans and thoughts without necessarily having the upset or distress obvious that you would expect. So, you know, the affect doesn't change as you might expect. And that can lead the uninitiated psychiatrist to underestimate the suicide risk. So tips for a better risk assessment, well, you know, be clear and precise and straightforward in your language. Really try and establish the patient's baseline and has there been any change from the baseline that might indicate, you know, a comorbid psychiatric disorder. Gathering collateral information, particularly from family members, is really important when it comes to that. And you may need to focus more on behavioral changes like changes in sleep, appetite, or repetitive behavior, rather than the patient's own self-report of how they're feeling or what their mood is at the moment. Right, let's go back to Lizzie. So you very wisely speak to Lizzie's mother, and she tells you that Lizzie's been more withdrawn over the last 2 months, talking less, rarely leaving the house, spending less time on her usual interests like craft, and she's eating less and has lost weight. And Mum also suspects that Lizzie's been self-harming again by cutting. And she's been talking recently about being a burden and thinks she'll never be able to live independently. So by now, alarm bells should be ringing that actually Lizzie has quite a high risk of progressing to a suicide attempt here. Some of you may be familiar with Joyner's interpersonal model of suicide. So it's one of the main psychological theories of why people attempt suicide. And there's basically three areas here. I am alone, which is thwarted belongingness. So it's feeling like you don't fit in and that you lack that social network. I am a burden. So, feeling like a burden on others or relying on others a lot for support, which Lizzie does with her mum. And capability for suicide. So things like self-harm increase your capability for suicide. They kind of reduce the threshold for progressing to a more lethal suicide attempt. And when all of those three factors intersect, then you can get at this high risk of suicide. And it's thought that in autism, all three of these things can be generally higher than the general population. So how are you going to manage the risk in your patients? This illustration is taken from our risk assessment document we've developed in Leeds, but it's really an internal document, a narrative form, one that we find helpful. As far as I know, there's no national or international validated autism-specific risk assessment tools. So it's best to just use your local trust risk assessment tool. Bear in mind, it's not a one-size-fits-all approach. All autistic people are different, so it needs to be personalized. It's always good to modify the triggers or precipitants for risk for suicide attempts where you can. We talk a lot in the autism world about scaffolding. So that's the support around the patient, not just family and friends, but also professional support and things like activities and even employment. So if you can increase the scaffolding around the patient, that reduces the risk usually. Be aware of your local autism office so that you can check that out usually by checking your local authority website, and that'll tell you which autism services and charities are available in your area, which can be a big help. And remember that depression commonly co-occurs in autism, and treat any depression. You may need to make reasonable adjustments, like, for example, starting a lower dose of antidepressant, but our treatments for depression do work in autism. So I'm just going to wrap up now with the key points. So whatever field you work in, whatever specialty you work in, you will come across autistic patients. And the risk of death by suicide is in the order of 10 times higher in this population. And there's various risk factors, some shared with the general population and some more autism specific, such as camouflaging. The assessment of suicide risk can be more difficult, but it's certainly not impossible. And by and large, manage the risk as per your non-autistic patients, but I would advise you to have a higher index of suspicion. If you have an autistic person and they say, I want to kill myself, and particularly if they've got a kind of thought through plan, then really take that very seriously, because they don't tend to lie. And always remember reasonable adjustments, both in terms of your medication treatment, but also psychological treatment and your general communication approach. And I think these will be on the slides when we share them, but they're just 3 references really that I think are of interest to the general psychiatrist. So I'll hand you back to Tom now.
Thanks, Conor. We now take questions and answers. And perhaps because several people have asked, has there been an increase in admissions to acute wards for patients with autism due to COVID-19 situation? One person has written and say he's experienced an increase in admissions on his own ward. Wonders about the experiences of others. And I wonder, Ian, do you want to take this first?
Yep, sure. I know some people said I was very fast, so I'll try and speak slower. But we don't know is the true answer to that. What we do know is that, for example, in the autistic community that we support, some people did well with the very strict lockdown because the rules were very clear, and that helped. But a lot of people struggled because they lost the routine, they lost things that normally supported them. So we have seen an increase in contacts for our support line. We have seen an increase in one-to-one contacts. And we have also helped our crisis resolution home treatment teams to support people who otherwise would have been admitted. But we've also supported some people who have needed admission. Across the country in England, I can only speak for England here, one of the big difficulties is that we often don't record diagnoses in what's called the mental health minimum data set. So it's very difficult across England to say what proportion of autistic people are in mental health services, because in England we have moved away from recording diagnoses, never mind a secondary diagnosis or a tertiary diagnosis, even a primary diagnosis. So most of this is anecdotal. We're working on those issues to get better data collection in the future. But from the feedback I'm getting from around the country, some people have been very badly affected, have ended up having severe mental health problems. Other people did much better during the lockdown. The mixed messages we're getting at the moment are actually in many ways the worst situation to be in, because people don't know what the rules are. That's not just autistic people, that's everyone, but that's a more challenging position for autistic people.
Thanks.
Can I just add, Tom, that we did a survey in Leeds on autistic people's response to COVID, and we found that 71% of respondents said their mental health had got worse, either somewhat worse or significantly worse. And the things that seemed to most affect the people we surveyed were the kind of uncertainty around what will happen next in terms of the pandemic. And they also spoke about having less access to normal sources of support. But I did ask my trust whether we'd seen an increase in autistic admissions, and they were totally unable to tell me because, as Ian says, we don't capture that data properly.
The next thing, Mary, I wonder, comment here, I wonder if it would be helpful to make a brief comment on the autistic person as against person with autism terminology. Person first, condition first.
Yeah, my perspective on this is I would absolutely respect any individual's right to identify however they choose. However, when referring to us as a collective group, I think it's important to respect the usual majority view, which really is autistic person rather than person with autism. And if you consider any time person with anything is used, the anything, the qualifier, is always something negative. So for example, you might hear about a gifted child with autism. You'll rarely hear about an autistic child who's gifted. And it just, there's no way to separate autism from who we are. It is our identity. It is our way of being in the world. And autistic's not a bad word. And yet, obviously, some people do prefer to identify as a person with autism. My view on this has evolved over the years, and now, no, I mean, I'm a doctor. I'm not a person with a medical degree. It's the same thing. I'm a mother. I'm not a person with a child. It's who we are.
Thanks.
Just to come in on that one, just to confirm, College Council agreed when I presented them in January that the default term in the college will be autistic person, unless the person prefers a different way of using it. And
Mary, again, you mentioned how you found it easier to talk to patients compared to peers. Mm-hmm. Would you be able to go into that further? Would you feel, how do you feel that's the case? Absolutely. And are there any measures you've put in place to help with communicating with peers?
There's no comparison. Communication with patients it's not quite scripted, but it is definitely structured. I have a particular role, they have a particular role. I have information that I need to elicit, and then I have information that I need to impart. There isn't a lot of unpredictability within that interaction. Peers, goodness knows what they're going to come out with. And also it's all the non-verbal stuff. There's lots of politics, there's lots of interpersonal communications, there's lots of interpersonal relationships that I'm just not necessarily intuitively aware of. So it's just exhausting. So I'm, I do struggle much more with peers. I find disclosing is great, letting people know, because again, I have to put so much effort into seeming like part of the team, chatting to people, greeting people, doing all the small talk, doing all that. And sometimes I forget. I'm off in my own world thinking about something else. So it's really useful for my colleagues to understand that if I blank them, also I'm a bit face blind as well. So if I don't recognize them, maybe out of our theatre environment or whatever, and that's not necessarily in the supermarket, that's often in the corridor in the hospital. Just so long as people understand, I think it helps. It helps a lot. So I found that being able to be open with my colleagues really helpful.
Thanks. Sorry, there's a plethora of questions. Trying to sort of. Conor, a question's asking, is the case of Lizzie a real one? And if so, has she undergone a clinical formulation with the help of a clinical psychologist? In general, do you routinely do a clinical formulation for the adults with a new diagnosis of autism?
Well, the answer to Lizzie being a real patient, she's not a real patient, but it's very similar to many patients that I've seen in my work in CMHT over the years with autism. So she's a kind of amalgam of a number of different patients. And the question about formulation, I think, is just really so important. And there's a risk in the autism world that you can kind of get sucked into this binary idea of do they have autism or do they not? And of course, life is a lot more complex than that. So I think in the formulation, you do need to take into account all the different comorbidities that are often present in autism. And we also try and take into account kind of life events and the impact of trauma and so on. We know that trauma is more common amongst autistic kids, so that's a factor too. And we also look at the wider psychosocial context. So we see a lot of patients in clinic, for example, who are having problems with employment. And often it is kind of peer relationships in the workplace that seems to be a big issue. And so we aim to kind of factor that into our formulation as well. So yeah, it really has to be a biopsychosocial formulation.
Yeah, and can I just endorse that, Tom, that that's what we're pushing for at national level in England. That's what we're pushing through. The old days of the one page, yes, you're autistic or no, you're not autistic, they were not helpful. What we want is a proper formulation based upon strengths, needs and aspirations, which, as Conor says, takes into account all the various aspects. So yeah, absolutely, that's not just the college, that's a national push.
Right, to this one, to Conor first, but then to Mary. What in your experience the main voiced reasons to die for the suicidal adults with autism?
Yeah, I think I'd probably go back to something I said in my presentation, which is that the most striking kind of difference I've seen in some autistic patients compared to non-autistic patients is this sort of logical thought process that I have this problem. One person who'd lost his job, for example, and had done lots of interviews and couldn't find work. And he just concluded, you know, I can't work, therefore I'm no use to society, therefore I'm going to end my life. And it struck me that he didn't seem to have a kind of overlying depressive disorder. It was just very much, this is the next step in my thought process. So I think that's the biggest difference that I've seen compared to neurotypical patients.
Mary, do you want to pick up?
I'm going to have to ask you to repeat the beginning of the question, Tom, because you froze for me for a second on that. I know it's about suicide, but I didn't get the actual, and I've been looking for it here and I can't find it.
The main reasons voiced by adults who are suicidal.
Yeah.
It goes back to your study, and that's why.
Yes, it does. That's an entire other talk we could spend an hour on.
We're running over by a few minutes because of the break.
This world is a really hard place to be in as autistic people. This world is designed for you guys. It's designed for neurotypical people. It's not really designed for us, and it is a really hard place to be. A lot of autistic adults are so traumatized from just trying to exist in the world that sometimes we just want to leave it. And also, personally, I find that I can spiral very quickly into very nihilistic type thinking. And I know that a lot of my colleagues would do that. My friends, peers, colleagues would also see suicide as a rational option. It can be up there with a lot of other options. And the one thing that we need to be careful about is sometimes when we talk about it, we can talk about it quite dispassionately. And that can be quite disconcerting for people listening. So I have a very clear safety plan. When I know that my thoughts are heading in that direction, I know who I can safely talk to about it and who I can't. And I find that being able to talk about it with safe people increases my own safety. And I would recommend that for other autistic people, just the freedom to be able to talk about that and have it understood.
Thank you very much. I think we need to stop at that point. There are a load of questions that we haven't addressed, but we'll try and answer a number of them online. Thank you very much.